Great. So thank you all. As I said, there are more people waiting, but we'll crack on for a second. Thanks for joining. It's really great pleasure to introduce Emma Svennberg to the group. So Emma's a real star in screening and detection of AF and has led a number of really critical clinical trials on atrial fibrillation and was a member of the task force of the European Society of Cardiology Guidelines on AF. So thank you so much, Emma. I think you're going to teach us all a little bit about what happens when our devices beep about AF, which is really great. It's always the questions that we get most when we have these sorts of meetings. So we have a real great engaged group of mostly primary care, but also across the span of healthcare. So thank you for joining, and be great to hear your thoughts on this controversial topic.
Delighted to meet you all, and thanks for the invitation. I will stop my video as my bandwidth is a little low here and share my slides. So today we will really put the focus on why does the watch beep and what should we do about it? And we'll discuss a few simple steps that we all can take in case we get one of these alerts from a watch. As Deepak alluded to, I was a very proud member of the ESC 2024 task force for the atrial fibrillation guidelines. Please notice my other conflicts of interest. So why is it important then if a watch beeps? Well, we do know that there are some risks associated with atrial fibrillation, an increased risk of ischemic stroke, in addition, an increased risk of death. And this risk is, of course, independent of the symptoms that the patient has. We do also know that we can treat clinical atrial fibrillation with an oral anticoagulant to reduce this risk of stroke and death. However, what is it like for patients with watch-detected atrial fibrillation? How does it work, and how can we manage it? And that's what I want to go through with you in the next few slides. First of all, how does the watch work when it comes to gathering information about heart rhythm? Well, the watch can work in two different ways. It can work in an automated way. That means that the watch will by itself monitor heart rate information from the wearer. It can also be manual. That means that the wearer themselves have to activate the watch to record a registration, commonly by pressing the bezel of the watch. What should we then do in case of we have a watch-detected atrial fibrillation episode? Well, I think we should always go back to the management by AF care, and we'll discuss the different steps in the AF care pathway. But first of all, let's zoom in towards how the watch works for AF detection. So the watch can work in a very simple way, in the manual way. That means that the patient or the wearer of the device themselves activate the watch to take commonly an ECG. What the person will then do is, in case of symptoms or on a regular basis, they'll check their heart rhythm by taking an ECG, by pressing on the watch device itself. Then you will get an ECG registration, commonly in lead 1, and that you can watch and that the patient can download and show to you as a PDF registration. Now, a single lead ECG can be diagnostic for atrial fibrillation if you look at the registration itself and deem it to be atrial fibrillation. So in that case, you don't need to do anything except to look at the registration and determine if it's AF or not. But commonly, the watch works in an automated way. That means that in the background, the watch will monitor heart rate, and it does that by using a modality called PPG, or photoplethysmography. Now, this is a complicated name for something that we use a lot in the clinic, for example, through pulse oximetry. And how all these PPG devices work in watches or in pulse oximetry, for example, is that the device will emit usually a green light towards an area where the skin is very shallow, so the bloodstream is quite close to the skin, for example, at the wrist or at the earlobe. Once the pulse comes, you could see that the green light will go towards the bloodstream. As green is absorbed by red, more light will be absorbed and less will be reflected back to the reflector or the detector inbuilt in the device, and this will create a pulse wave. From this, the device will have an inbuilt algorithm to determine whether this is atrial fibrillation or not. Here we can see a comparison between different modalities where PPG then uses a generated pulse waveform to derive the heart rhythm from that. Whereas an ECG, of course, we use electrodes that generates an ECG tracing, and we can directly look at the heart rhythm, and that is also, the ECG is also diagnostic. There are some difficulties using PPG. One of them is that the studies are commonly using very highly selected populations, and that all the reported data is really, really good. That usually means that there is some publication bias. There is some data where the results were not so good that were commonly not published. We can also see when we look at different types of PPG monitors that the standards are very different between different types of monitors. They use different wavelengths of light, They use different sampling frequencies. They remove noise differently. So this means that there is no true standard yet when it comes to PPG monitoring for heart rhythm. So it's difficult to compare the different devices with one another. So therefore, according to the ESC guidelines, we still need an ECG to diagnose atrial fibrillation. But how does the watch work then? So this webinar is about when will the watch beep, and the watches have different inbuilt algorithms, but I'll show you an example of one of these automated algorithms that will work in the background without the patient doing anything to activate the watch. And what it usually does then is that it'll start to monitor heart rhythm when the patient is resting. And what it does then is that it does a PPG monitoring every 2 hours for 1 minute. So it will monitor heart rhythm by itself, like every 2 hours when the patient is still. In case there is an irregular heart rhythm episode, here noted as red, it will start to monitor the heart rhythm more frequently using PPG, so sort of every 15 minutes. And in case it notices that several of these tachograms are irregular within a 48-hour period in this example, it will send a notification to the wearer. So this means that you have to have a prolonged episode of atrial fibrillation, or indeed very frequent episodes of atrial fibrillation for a watch to set off an alert. If we look at the alerts, how sure are we that it is atrial fibrillation if this PPG method says it is AF? Well, in 2 studies they've looked at this. Well, let's look at the first one using the algorithm we saw on the prior page. In this study, 86 participants got this kind of notification and were simultaneously wearing an ECG patch. Out of the 86, 72 were then confirmed to have atrial fibrillation. So that means that the positive predictive value was about 84%. In a different algorithm seen below, using a different device, that was higher. And this depends on the algorithm of the device. But from these different studies, we can see that these automated alerts commonly suggest atrial fibrillation. They're quite commonly right, but we do need to confirm the diagnosis with an ECG. What about if the patient does a manual registration of the ECG? than using the watch. Now, here is a comparison of 5 of the most commonly worn or wrist-worn devices, and we can see if you use the smartwatch's own interpretation of the data, that the accuracy across these different devices, it isn't that good. Even if we allow the algorithm to take away motion artifacts, it's still not that great. But if we compare it with a cardiologist interpretation and compared to a 12-lead ECG, we can see that then these devices provide quite good accuracy. So a learning point here is that we really do need to monitor the ECG to improve the accuracy of the device. Okay. See if I can move forward. Yes, there we go. So what do we do then? Now we have a patient, we've clarified that they do have atrial fibrillation on the watch, we've confirmed it with an ECG. Then what do we do? Well, let's all remember that there are a few simple steps we can do for all patients. We should, according to the ESC guidelines, start with the AF care pathway and start with the C, comorbidity and risk factor management. And within the guidelines, there are very good steps of how to follow this path. I'll just simply show you that in this study using devices, that actually patients who manage their comorbidities fared a lot better. So this we can do for all patients who have atrial fibrillation detected. But a common question I usually get is, what do we do with oral anticoagulants then? Because that's the next step in the AF care pathway, right? The avoid stroke and thromboembolism. Well, when we look at oral anticoagulant treatment, or specifically DOAC treatment, we do know that some patients have a very low risk of getting an ischemic stroke. They are below this dotted red line. So these are not likely to benefit from oral anticoagulant therapy. The rest of the patients in the yellow and the red zone, they have more benefit of oral anticoagulant therapy, and in particular, if you're in the red zone. If we look at clinical atrial fibrillation, well, most patients end up in this high zone. And we do know then for a few that maybe if they have a very low Shad-Svar score, for example, that the risks go down to low and they might not need treatment. But for the very most of them, they do need treatment and are at a high risk. When it comes to other ways of detecting atrial fibrillation, such as through screening, we do know that they have an increased risk of stroke, but the risk is not as high as for clinical atrial fibrillation, and that's regardless of the method of detection. We can also detect atrial fibrillation using implantable loop recorders that monitor the heart rhythm all the time, or through devices such as pacemakers. These patients have a very low burden of atrial fibrillation, so very few episodes commonly occurring very seldom. And they are at a lower risk of stroke, but this risk can be increased in case, for example, they have high Shad-Svar scores. But what do we now do with the watches here? Or how should we think about them? And I think the most common semblance here is probably of screening detected or device detected atrial fibrillation. And here the guidelines recommend that direct oral anticoagulant therapy may be considered in these patients with asymptomatic device detected atrial fibrillation and an elevated thromboembolic risk to prevent ischemic stroke. And here we should exclude patients at a high risk of bleeding. So this is how I do manage my patients with regards to oral anticoagulant therapy. What about the other steps then in the AF care pathway? Can we use the watch for these steps? Well, there is now a new feature in some of these devices where you can turn on AF burden for patients who already have known atrial fibrillation. In these patients, the watch will monitor the heart rhythm every 15 minutes for a minute in case you wear it at least 12 hours per day, 5 days a week. And then the patient will get a burden or a history of how much AF they were in on a weekly basis. Now, this has been validated and FDA approved as an endpoint post-AF ablation. So does it help our patients to monitor the heart rhythm? Is this good for the final step of the pathway evaluation and dynamic reassessment? Well, when it comes to wearable users compared to non-wearable users with atrial fibrillation, in this propensity scored matched study, could see that patients who wore wearables actually had more healthcare use, visited their primary care more commonly, were quite preoccupied with symptom monitoring, and had greater concerns with their treatment. In addition, 20% of them always contacted their doctor in case of an AF device notification. So it is not always, it does not always bring down the healthcare consumption to have a wearable device, for sure. So to summarize then briefly, when the watch beeps, well, this is commonly due to an automated algorithm, and that is not diagnostic for atrial fibrillation. We do need to confirm that they have atrial fibrillation by an ECG recording. How do we manage it then? Well, I think we should follow the AF care pathway. When it comes to C, be aware this is very important. We can do this step in all our patients. It's commonly something that we are not as good at doing, especially, I would say, as cardiologists. When it comes to oral anticoagulants, there are no studies on watch-based AF detection and oral anticoagulants. So what I do now is I treat them like device-detected AF. When it comes to R, rate control, we can certainly monitor them using the AF burden. And when it comes to evaluation, be aware that healthcare consumption can increase using wearable devices. So with that, I'd like to thank you for your attention so far and open up for questions, of course.
Great, thank you, Emma. Fantastic review of a really difficult area, I think, for everyone. Please feel free for those on the call to chat. You can put in your questions there, or raise your hand or something, and we'll come around just whilst you're all thinking. It was great. I mean, you kind of really nicely distinguish between kind of ECG detected AF and the sort of light sensors or whatever else might be algorithm type stuff. I guess if some of our primary care practitioners out there get someone coming to them, is there an easy way to know whether some of these devices are what, and is that proportion changing now? Because I seem to see a lot more smartwatches which presumably could do ECG, but some of them are also PPG, right?
Yeah, this is the difficult bit, and what I commonly advise to do is there is a simple guide, a practical guide on digital devices published in EuroPace, and we have listed all the devices and all the validation studies performed. So there's one piece where I can simply look it up there if one is unfamiliar with it, but mostly what my patients are still, if I don't recognize the device, it's commonly PPG because it's so much cheaper and you can buy it over the counter, whereas ECG is a little bit more difficult to get a hold of, at least in Sweden, unless you've got a watch.
Great, and so really it will depend on that distinction as to how much you kind of value the information you're getting, right? So what would be the kind of practical implications for, particularly in general practice, if patients are getting these beepers, and at what point do you then consider referring on to the secondary care services, AF clinics, and so on?
Yeah. So in a patient who comes in and has received an alert on their smartwatch, commonly they have quite a high burden of irregular heart rhythm, and many of them do have atrial fibrillation. So I would not just discard that. I would probably monitor the patient using an ECG, in particular if they're at a high risk of a stroke. If this is a very young patient where you would not treat them with oral anticoagulant, I would probably go for the comorbidities management first. That would be the most important, I think, for that patient. But otherwise, always confirm with an ECG using a prolonged monitoring, if you can.
Great. And there's a question in the chat then, which is related to that. So what's your advice on if a patient has intermittent palpitations, so they have symptoms, but you can't capture it on even a 7-day tape, but only then on smart devices? So I guess that's a potential opportunity then, isn't it? But what's your advice there around the kind of patient who has this difficult to capture AF?
I think this is as soon as you put anything on the patient, they will never be as arrhythmia-free as they are in that period of monitoring, right? I think we see this all the time, that they are asymptomatic once they're monitored. So what I try to do is see if they can monitor their heart rhythm using some sort of intermittent ECG device. If you have that in your clinic and you can borrow it to them, or in your cardiology outpatient clinic, then they can take the registration when they have the symptoms, and that can be, you can have that at home for a more prolonged period of time. So usually I think if they're truly symptomatic, then they can have some sort of device where they can by themselves activate it to take a registration and bring that with them. There are many different types.
Presumably, though, then that should be an ECG type device.
Yes. Yes, because otherwise you're still stuck with having to repeat the monitoring anyway to get to diagnosis. Okay,
great. So hopefully that answers that question. I think it's interesting. I think these devices are obviously becoming a lot more common. You know, I know certain GP practices, for example, that have the ECG within the device that they can actually check while they're in surgery. So I think these things are becoming a little bit more easy to deploy, even in difficult situations and community circumstances. Obviously, it's a lot easier for us in the hospital because we have multitude of ECG machines just lying around, and that can be done relatively quickly. But I think these sorts of things are potential. Great. Are there any more questions in the call? Oh, there's one there. This is from Ven. So with the increasing wearable device use, do you have an idea of the percentage of patients who have had AF diagnosed on their smartwatch wearables compared to Holters? So basically trying to get an idea of the workload that we're likely to face in coming years, I guess. But yeah, so I mean, I think you alluded to that in one of your slides there, but in terms of the smartwatch wearable devices, what are we likely to see is the conversion to AF that will then need treatment?
Yeah. Well, thank you, Ben. And we don't know the percentage of diagnosed with wearables compared to clinical AF. Very early on, a few years back, they did sort of a registry study in the UK just after the smartwatches were released, and then they couldn't see an increase in the clinical diagnosis of AF, but I think that has shifted, and I do see quite a lot of patients these days that have gotten their diagnosis using a wearable device, or get to diagnosis using wearable devices. I think as always, when we are using new technologies, that we need to implement them within our healthcare workflow. So right now, I think there's an abundance of devices where the tech companies have come up with a solution for consumers to use these devices, but we haven't implemented that really in our workflow. So I think we need some sort of umbrella organization where patients who are monitoring their heart rhythm can send in their registrations, and we'll look at them, at least from a hospital point of view, because I don't want to have unsolicited sort of recordings coming through my email at different time points. I find it very difficult to know who's responsible then. So I think we need to organize this better within the healthcare setting for it to not become a burden, but an opportunity.
Yeah, no, that's really great. And Ben has agreed that I think the implications on workflow are massive, aren't they, for all these technology advances, not just in AF. We're seeing it across the board, aren't we, for different conditions. Diabetes took a kind of a really central role for a long time, but now the sort of tech world is catching up to other parts of that. So it'll be a really exciting time. As you said, it's an opportunity for prevention, I guess, that we've never had before. So we've got to try to jump on some of those opportunities. Well, thank you, Emma. Phenomenal as always to hear your thoughts on this topic. Maybe it'd be great in a few years' time to get you back and see where things have changed, because it's such a rapidly moving field. So it's very exciting. So thank you, and thanks to those who've asked questions. And so we'll hand over back to Alistair for the rest of the meeting. Thanks.
Thank you, and let me just echo Deepak in terms of that was incredibly interesting and important presentation, particularly for clinicians and also like people like myself that has one of these smartwatches. So thank you very much for that. So I'll quickly share. So this is one of a series of CPD sessions that we in the DaRe2THINK trial team have been running over the course of the last year or so. For those that don't know what the DaRe2THINK trial is, the DaRe2THINK trial is a National Institute of Health and Social Care research funded collaboration between the University of Birmingham and Clinical Practice Research Data Link. The project is looking at using routinely collected healthcare data to integrate clinical research into usual NHS care. We're looking to reduce the burden of research on both NHS staff and patients. And the DaRe2THINK trial is an exemplar of this new delivery method and targets a key public health issue of how to prevent cognitive decline and dementia in patients with the heart rhythm disorder atrial fibrillation. The rollout of this new delivery method has so far been successful, and we are able to screen from over 13 million NHS records to identify potentially eligible patients. Over 450 GP practices are already actively screening and recruiting patients to the trial in the UK, and we are also currently seeking new practices using the EMIS Web electronic healthcare system to take part in the trial. We've had a great uptake into the trial from patients, with over 1,100 patients now recruited, and with over 20% of patients invited to take part by their GP interested and taking part in the trial. Patients can take part in this study completely remotely, and it enables patients to take part without leaving their home and reduce the burden on them and also the NHS staff that take part. So we're continually working to improve the study and have now successfully launched a new and improved delivery platform to support the trial. And this is a call out to all our current practices, if you're on the call, to book a meeting with the team today using the QR code on the left, and we can guide you through the use and how this new system has improved the trial even further. And to all those practices that aren't currently taking part, but today, the important information that we've heard from Emma and also the information that I've just shared and has interested you and would like to take part in the trial, please scan the QR code on the right. We're always looking for new practices, and a member of our team can talk you through the trial processes and get you set up as quickly as possible. So that just leaves me to say thank you again. It's 12:30, so we've finished perfectly on time. And thank you for joining us today for our CPD session, and we look forward to seeing you in the future sessions. So thank you and goodbye.